sense in COVID-19. My name is Bob Schwartz, and I serve as a Director of Special Projects for MU Extension's Business Development Program and the Small Business Development Center, and it's my honor to serve as moderator of today's webinar. We appreciate you joining us. Before we get rolling, let me go through a few brief housekeeping details. I'll introduce our speaker and then we'll begin today's program. First, let me thank Amy Patillo and Matt Pezold for their work in putting together the Workforce webinar series, including today's program. This webinar will be recorded, so you'll be able to access the webinar and slides following the program. And for our format today, we'll have about 35 minutes of presentations, followed by about 20 minutes for questions. Please go ahead and put your questions into the chat, and we'll address as many of those questions during the time we have today. With that, I'd like to introduce our speaker. Dr. Carolyn Orbann is a medical anthropologist who studies patterns of infectious disease spread in rural and indigenous populations using computer simulation models. She is interested in a way that specific cultural behaviors can influence disease spread and how the incorporation of culture can increase the validity and utility of computer models of infectious disease. Her previous work includes participation in the development of a model of the 1918 flu in a village in rural Newfoundland and the development of a model of a measles epidemic in an early 19th century Californian community. With that, Dr. Orbann, the floor is yours.
Thank you so much for inviting me to be here. Let me just get my slides here and make sure that I can share my screen. So I'm going to go ahead and share my screen. Let's see. And then I'm going to turn on the actual presentation so you can see that. Should go. Okay, so I had forgotten that I had given a bio to be read, so I put a few things about myself on this, so I'll just move through this part quickly. But especially since I have the high school class here, I just thought maybe it would be nice to know a little bit more about what biological anthropologists do. If you've heard of anthropology, you probably know then it's the study of humans and human behavior. It has multiple subdisciplines, and so biological anthropology is one of those. We are people who study humans as kind of organisms. We try to understand the relationship between human behavior and human health in the short and long term. I specialize, as I've said, in historical epidemics and small scale populations using computer simulation models. So there's other folks who would say use skeletal materials or use other kinds of ancient DNA, for example. I use mostly documents, archives, and computer simulation models. So that's kind of what I do in my research component of my life. My main job here with the University of Missouri is actually to teach in the Department of Health Sciences, which is a large undergraduate department at our university in the School of Health Professions. And I teach classes in health policy, culture and health, and I lead our study abroad. So I kind of have a broad set of duties and things that I'm interested in, and I work with students. So for those of you, especially students who are here, welcome. I'm glad to see you here. So I'm going to kind of get through what I would like to in hopefully about 35 to 40 minutes, because I would like to hear about your experiences out in the community as well. One thing that anthropologists are trained to do is to listen to how people talk about their experiences and to think about what they're saying on the surface and what they're saying in a more symbolic or interpretive way. So I'm really interested in hearing about people's experiences as well. But I just thought I would start with some kind of basic background, and I'm not trying to teach anyone too much. I know it's summertime for many of us, but just thinking about health from an anthropological perspective, the way that I approach it, one of the things we need to think about immediately is what are the guiding principles that people use when they're making their health choices? If you've taken a public health class or you know anything about public health, this model on this slide should look familiar to you. It's a socio-ecological model whereby people's decisions are based on a number of factors at varying levels of analysis. So you have the individual there in the very kind of middle smallest circle, and their healthcare decision or their health decisions are are based on some of their own autonomous kind of decision-making powers, but they're also based on the relationships they have with other people in their life, what's available to them in their community, and then what society is telling them is the right or proper thing to do or improper or wrong thing to do. So any decision that you make, and this isn't only for health decisions, but this can definitely be applied to health decisions, is based on a number of these factors at different levels of analysis. So if, for example, if you're in a community that has a hospital, your decisions about some of your healthcare is going to be a little bit different than if you're in a community that doesn't have a hospital. So that would be something that is at the societal level or the community level. Your decision whether or not to eat meat may be more an individual decision, or a decision that is kind of fluctuating between pressures that you face as an individual and your relationships. So these can, all of these kind of concentric circles have a role to play in individual health decision making. So when I'm thinking about common sense from my perspective, I'm trying to think about what is common sense, how common is it, for example, and where is it actually coming from? What level of analysis? For many of us, the idea of common sense is something that exists beyond the level of the individual, right? It exists outside of us. It's not something that I came up with on my own from my own experience. So it's probably kind of functioning out there at what I would call kind of the cultural level, something beyond the individual, out there in the relationships, out there in the family or larger society. So common sense is really interesting thing to think about when it comes to health, because many of the things we think of as common sense health behaviors aren't really that common sense in terms of they vary widely across cultures and across communities. So whether it's proper to wear shoes inside your house, is that a health decision at all? Do we think of that as a health decision in our communities? That varies across the world. Some people see that as a very, as an important health decision that you don't wear shoes inside the house. I find most American communities are kind of neutral about that. So there can be surprising variation in common sense in cross-cultural contexts. And so I think that's really important to know first off. Even if you don't know each little detail, just know that there's a lot of variation, and sometimes it's very unexpected where that variation is. So next, to think about how we learn our health behaviors. And this, again, this model can be applied to learning a lot of different things, not just health behaviors. But there's a couple of different avenues that we tend to learn things as humans. Humans are a social species, so we live in groups. We have lived in groups as long as we've been a species. And one of the main modes that we learn some of our deep cultural learning is through what's called vertical transmission. And just like this picture is demonstrating, vertical transmission is things that we tend to get from elders to youth. So this kind of learning is how we learn language, it's how we learn religion, mostly it's how we learn things like diet, proper behavior, what we would consider manners. All of these things tend to be vertical. So there are certain kinds of health behaviors that you would learn through this vertical avenue. And that tends to be a little bit more one way, right? If you're a child, you're typically learning from your parents, you're not teaching to your parents. So there's a lot of other things we learn through vertical transmission, but most vertical transmission tends to happen in childhood. This avenue kind of declines in importance as you get older. It doesn't go away, but it declines in importance. And the kinds of things that you learn change. So me as a person in my 40s, I'm no longer learning how to brush my teeth. As the picture here, the mother is teaching the child about dental hygiene. I'm not learning that from my parents, but I'm learning different kinds of lessons from my parents now. Horizontal transmission, if you think about vertical transmission being from one generation down to the next, horizontal transmission is when you learn across a generation. So this would be the kind of learning that you learn from your peer group. So this is here, I've given you a negative example here as opposed to the positive example in the previous slide, but there can be negatives and positives in both avenues. So horizontal transmission is usually peer group transmission. This kind of learning actually tends to be very fast. Right? If you think about, especially you those in the audience who are teenagers, think about the way that fads come and go quickly. They come through a peer group, they go out of a peer group very quickly. Things like slang, things like what is cool in terms of dress or hairstyle or makeup or anything that's kind of style related that kind of comes and goes quickly. That's often through a horizontal transmission, mode of horizontal transmission. We also know this is an important avenue during adolescence. That's one of the most significant times for horizontal transmission. Again, this does happen throughout your life as you have different peer groups into adulthood, but it tends to be very intense during adolescence. So Here you see an example of, teens and substance abuse. And so you see a variety of things here, from vaping to drinking to perhaps marijuana or something like that. So this is a negative example. There can definitely be positive examples. And then kind of the last one I wanted to mention is what I might call created knowledge. And we access this in different ways across our lifespan. Created knowledge would be knowledge that we gain through whatever our knowledge creation system is. And that's just a fancy way of saying, like in American culture, that would be science. Science is a knowledge creation system. We learn new things through this systematic exploration of the material world. It could also be through humanities, right? There's ways that humanities kind of help create knowledge. But in the case of health-related behaviors, usually we're thinking about what's called the evidence base. So scientific expertise. This kind of comes and goes. Generally, a person has to seek this knowledge in some form or another, right? It's not the kind of thing outside of a school setting, right? So schools for adolescents, that's an important place where we get scientific knowledge. Otherwise, we have to seek it as citizens. And that can be a little bit tricky because of the pace at which scientific knowledge changes and the way that it gets interpreted, reinterpreted, or miscommunicated. So this is an important avenue for knowledge creation, and influencing health behaviors, but it's also quite tricky in getting from the experts who know the information very, very well out to the community where it needs to be used. And that's where a lot of the mistakes happen in terms of miscommunicating or kind of coming into conflict with cultural values. And so these three avenues provide opportunities for molding health behaviors. So the bigger question that I have as an anthropologist is then, how do we think about these avenues of information transmission, and how do we turn them into what I've called here coherent health behaviors? We can use these. We hopefully don't want to spend too much time fighting against these, but we have to understand the different roles these different sources play across a lifespan, and how, in terms of public health, how public health professionals or even community professionals might use these different avenues to reach people that need to be reached. And so I'm thinking in the case of COVID specifically, right? What are the different challenges different segments of society are facing, and what are the best avenues for reaching people through the modes that already exist, these communication modes that already exist. And this is a whole thing. I could spend a whole nother talk on this, but I just wanted to kind of get you seated with this question, and then kind of go on to some more specific examples. Okay, so one thing I think about a lot is cultural identity. And cultural identity, using cultural identity is one way that we can reach people to influence their health behaviors. It tends to be quite tricky. Health behaviors sometimes are those specific things that help mark a people's cultural identity, right? So some behaviors that help people mark their identity as whatever, as a member of a culture, as a member of a community, also have health implications. Okay, so just an example, today is July 2nd. We're coming into a big American holiday. Here's an ad for McCormick Spices. Does this shout America or not? You know, we see lots of use of symbols, American symbols. We see an expected menu. What are the health implications of what you see here in this image? And if somebody came and told you, hey, this kind of meal that you're planning on having for the 4th of July is really unhealthy and you should probably not do it, how open would you be to hearing that piece of information? And how could that be modified to be more healthful? For example, is there something, if somebody said, hey, instead of a hamburger, could you have a veggie burger? You know, what are some things like that? So we're coming up into this patriotic holiday. It has a lot of meaning for a lot of people. It has expected rituals. I say the rituals because I'm formalizing the language, but you know what I'm talking about. Barbecues, fireworks, examples like that. It has things that have health implications. In this case, it's kind of a long-term health implication. Eating like this long-term is not good for your diet. There's also short-term health implications. This is an example from a research paper looking at fireworks injuries. And what it is it's a graph showing an age and sex distribution of fireworks injuries. And so what you see is that the darker, it's a little hard to see the color, but the darker, the higher peaks here are among males, and the lower peaks are among females. And then as you go to the right, you see differences in age. And so I hope you can see the difference here is that males are vastly overrepresented in having to be admitted for fireworks injuries to emergency departments. And so the other notion that I want to use this to illustrate is that sometimes these behaviors that have health implications that help us mark these events in our cultural life are not distributed throughout the population evenly, right? So in this case, males are much more likely to have an injury related to fireworks than females in American society. And you know, perhaps we can think about or talk about why that might be. So short-term, long-term health implications, but these are deeply rooted. Again, if somebody told you, you know, this fireworks are quite dangerous, there's no real reason to do them, according to, you know, I'm an outsider, now I'm telling you this, and Americans do fireworks 4th of July, there's no real reason to do them, they're very dangerous, you should just stop. You can imagine how that goes over. And so we need to think about, from a public health perspective, what is an acceptable mitigation or an acceptable alternative? Okay, so to kind of sum up just what I'm kind of saying here is that these identity-related behaviors can be very stable. They can be very entrenched or rooted. I'm trying to use a little bit of neutral language here, stable, because they have a lot of meaning in a cultural context. People see them as an integral part of something important to them. It makes them less likely to change over time. It makes them very difficult to change. If you're an outsider trying to change that behavior, it's very difficult. However, it can provide an opportunity for public health professionals who want to promote health. And so I'll talk about that in a little bit, some examples from the COVID context here that I think are kind of fun. You have to be imaginative to be in public health. You have to have a good imagination. You have to be a good listener. So I think all those things come into play when you're thinking about, okay, people aren't doing the things that are the best for their health. What are some ways we can perhaps change their behavior, shift their behavior? Okay, so I just want to transition to some ideas that I had about COVID-19. First, I wanted to make sure everyone kind of understood what the disease is. Hopefully we're all on the same page now, but just some of the highlights, the most current knowledge that I have. Obviously, it's a respiratory disease. There is some amount of asymptomatic spread. There seems to also be a lot of confusion about how much asymptomatic spread there is. So I'm just going to say there's going to be some asymptomatic spread. There's also going to be large numbers of people who have very mild symptoms. So there's kind of this confusing thing from a disease perspective, is this is a disease that lends itself to spreading. Anytime you have an asymptomatic phase where you can still infect other people, or you have mild symptoms where you can go out and be functioning in society while infecting other people, that's not great. There are some specific age-specific risks in illness and death. So there's been a long discussion about who's dying, what your risk of dying is specifically across age groups. And we know that the elderly are at particular risk in this specific disease. However, there are other social factors that seem to be playing a role here. People are at disproportionate risk if they have other kinds of what are called comorbidities. There are health disparities, serious health disparities that have already existed in American healthcare systems that are now being exacerbated in terms of who's getting sick and who's dying. Racial and ethnic disparities are some of the main ones here, where you have large numbers of people dying disproportionately on Native American reservations and in the Black community. Also, one of the things we need to continue thinking about is the access and availability of healthcare. So that's a particular issue for Missouri, where we've had a number of hospitals closing over the past 10 years. And what is that doing to people's ability to seek care should they find themselves sick with COVID? So not all the problems associated with COVID are cultural problems. Some of them are social and healthcare system problems. But the cultural can hopefully help understanding the cultural problems. So I'm going to use two examples here. The first I'm going to walk through is the social distancing issue. The other is mask wearing, and mask wearing is kind of the one that's come to the forefront as the most visible, but it may actually not be as big of a problem as it's being portrayed. So we'll talk through that. Okay, so social distancing, I actually thought when that term came up, again, put my anthropologist hat on, I've thought, well, gosh, that's an interesting way to think about it, because humans are such a social species. We have lots of things that we do socially, and those social relationships we have are so important to us. The idea that we could not do those things is very, very difficult. And in fact, what people were doing, what I perceive people to be asking, is not actual social distancing, but spatial distancing. They wanted people to literally be apart from each other. That's not the same thing as not having social relationships or social activities. And so in some ways, I think that the name social distancing actually isn't the best choice because it doesn't actually reflect what they were asking people to do, which was be spatially distant. And so you can probably think of a dozen examples of ways that people have stayed physically apart, but managed to do some of the social events that are important to us in our societies, right? So some of the questions with social distancing that I think we needed to resolve, and I don't know that we've actually gotten there, from the disease perspective, how long do we need to be in quarantine, right? And that's a question that can be answered by looking at the attributes of the disease. How long, if you happen to come in contact with the person who's infected, how long will it be until you become infectious and you know that you're sick or not sick? That's the space that you would need to be in quarantine. That's a different question from how long can we be in quarantine? Can we be in quarantine, right? And I think what we're experiencing now is a certain amount of fatigue. People are tired of being kind of locked down. And so they're starting to let their priorities be molded by some of these other pressures in their life. And so that's two different questions. And so we need to communicate the difference between these very, very carefully. What are things that cause people to fail in their quarantine? Oops, I'm sorry. To fail in their social distancing. So one of the things that I've heard the most in terms of just people in my life is as you start to miss those events that are very important to you, then it's harder and harder to stay in the quarantine, right? Sometimes those events are graduations. Then, I'm at University of Missouri, we canceled our graduation. Sometimes those things are birthdays, anniversaries, other kinds of get-togethers that are important, holidays where people would generally get together. So these are the things that tend to cause us to fail in general. So I put here, not to miss out on the big life events. Human societies, all human societies put a lot of importance into rituals, whether those rituals are kind of life events or yearly activities. So missing these big events and the traditional behaviors and activities that go along with these big events, that makes it really hard to stay in quarantine. The other thing is just a fatigue. You may have heard it called quarantine fatigue, just a desire for what we perceive to be normal. And to be honest, we may have to start to think about a new normal, right? That may be something that we need to work on as a society at large, is to kind of think about a new normalcy. Okay, so what are some of the best ways to preserve normalcy? I think there have been a really interesting number of kind of accommodations to events. You've seen the development of things like drive-by birthday parties or Zoom happy hours or really funny kind of little entrepreneurial things like was it Spain or France, where people were renting out their pets because they had a lockdown and movement restriction. But if you had a dog, you were allowed to take your dog out for a walk. And so people are actually renting their dogs out. It's kind of a joke. So I'm not sure, how pervasive this was, but just this idea that just, we value these things that allow us to feel normal. And we can come up with ways to accommodate the circumstances to feel normal again. Okay. So that's kind of social distancing. We could talk about that social distancing for a much longer period of time, but masks are something that I think is really worth spending some time on because it's become such a hot button issue, or so it seems. And I'll show you some data actually that maybe it isn't as hot button as we are told it is. I can tell you unequivocally, the public health view is that masks are effective at reducing transmission of a number of respiratory diseases. Even flus, even coughs, even regular colds. It's a good idea to wear a mask if you're sick. And this is from a USA Today article, and I have a link in the slides if you want to see it. There's also some animations there if you want to see the gas cloud that when you cough, how far the droplets actually go from your face. So it's unequivocal that masks are good for preventing respiratory disease transmission. So the question is, how come America doesn't have, specifically American culture, doesn't have a tradition of mask wearing? Not just now, but before now, because it would have made every flu season probably before now better and less flu, and every cold season better perhaps. So there's been some research, some of it predating COVID, that has shown that people are confused about recommendations. And I think that's something that's been kind of going around this week, is the whole, well, they told us not to wear a mask and then they told us to wear a mask, and now they're saying wear a mask or not wear a mask. I think the issue back in March was that there were shortages of the specific kinds of masks that healthcare workers needed, not that you couldn't wear your own cloth mask. So anyway, I think just people are confused about what kind of mask they should have and when they should wear it. The US doesn't have a culture of public mask wearing. So because we don't have that culture, people feel a little strange if they put a mask on and wear it out in public. There was actually some work done in 2018, so predating COVID, that asked people why they don't wear masks. And that was one of the biggest things. People didn't want to stand out. They didn't want to draw attention to themselves. They didn't want other people thinking they were sick. And so they would rather not wear a mask, even if they had a cough, which means you are sick. They would still not want to draw that attention to themselves. So kind of the fear of stigma. In some places in the US, face coverings are actually prohibited by law. Not a lot of people know this, but enough people knew it that it kind of disincentivized them from wearing a mask in public places. And then for very small numbers of people, we get to this kind of cultural identity, statement of identity behavior, that not wearing a mask is a purposeful thing, or in fact, wearing a mask is a purposeful thing that is communicating something. So the mask is becoming a symbol of a certain kind of ideology or a certain kind of lifestyle for some people. It's not very many people though. And I think that's where this intersection of the public health advice and the media, we're starting to get a little bit of conflict. And I can show you that. There was some research that was done in June from the Pew Research Center that looked specifically at attitudes towards mask wearing. So this isn't my research. I just read this report and I'm sharing this with you. But you can see here that most people say that they wear a mask most of the time, almost 2/3 of the American public, and another 15% say they wear it some of the time. Now, it's funny to me because 2/3 say they wear it all or most of the time, but only 44% say that all or most of the people are wearing masks at the places where these people are going. So there seems to be some little bit of confusion. Additionally, now the question here is a little bit deceiving because this is asking about kind of political leanings, but what I'd like to draw your attention to here is this top line where they said in the past month, so this was in June, so this is asking people about the month of May, had people worn a mask or face covering when in a store. And you can see 80% of the people reported wearing a mask or a face covering at least some of the time, and most of them for most of the time. So this is not really a controversial thing. We're being kind of told it's a controversial thing, but it's actually not. And even among the people who are kind of what you would call least adherent, so here among the white community, here among people who report to lean Republican or be Republican, it's still a large majority of people are wearing masks, right? And kind of the lowest amount of adherence is in those places where they perceive kind of a low impact of the disease. So the higher impact, so the places where COVID is circulating, you have almost 90% of people mask wearing voluntarily already and reporting that they do so. So it's perhaps this identity marker thing may be true for some people, but I think it's actually not that many people. Okay. So then I've seen, in fact, just yesterday there was an article talking about who it's okay to shame for not wearing masks, and I thought it was a humor article, so it was kind of tongue in cheek. But I will just say from a public health perspective, shaming is not usually a great idea. If you can think of examples of the kind of viral videos that have been going around of people confronting people and trying to shame people in public places, that usually doesn't go very well. And so, maybe we can talk about that. I'm having kind of a hard time seeing the chat. Oh, here we go. Yeah, okay, here we go. You can probably see the chat when I'm seeing it now, but yes, so those typically have not gone well. The ending of those videos is usually not somebody accepting a mask and gratefully putting it on, right? Which would be what you would like to see. Instead, it's usually some kind of blow up and yelling and storming out of a store. So from the public health practitioner standpoint, that's not a good resolution. Let me see here. So the problems, and these are well documented in literature, in research literature, is that when you have a disease where there's, or a condition or a health behavior where there's a lot of shame involved, it can cause people to not seek services that they need or to seek supports that they need. It can cause people to double down on bad behaviors. So you get kind of this righteous anger and feel like entrenched in your decision to make that decision. If everyone's telling you, it's kind of this counterintuitive thing. If you have all these people around you telling you that you're making a bad decision, it somehow sometimes makes you more likely to continue making that decision. It can cause stigmatization by society, which can lead to health disparities down the line. So being mindful of shame is not the best way to approach this. So if not shame, then what? I just want to make sure I'm getting questions. Oh, good. I'm glad to see. No shame. I mean, it makes for funny videos for sure, but you know, I would hate to be in that situation in that public place. So then what does work? And this comes out again out of public health, out of research. This is evidence-based. This is research-backed. I'm appealing to our shared cultural values of believing in research and science. That the best things you can do is to have a clear, unified message from people with what's called in-group authority. In-group authority is people who have trust in the community. And so this I'll say this later, but scale matters. You need to always be thinking about who you're talking to and who has that community's trust. So I think the decision by the coach of the MU football team to post a picture of himself with a mask, that's appealing to a certain constituency in our community, right? The decision by other people to wear masks in public and to post photos of themselves in masks, they're appealing to people who trust them and trust their authority. And who those people are, who those authorities are, is going to vary from community to community. Normalize mask wearing in public. So, you know, just wear one, and it might feel weird for you for a minute or the first time you do, but pretty soon other people will kind of be emboldened as well. So be a leader in that perspective. Don't stare if you aren't wearing a mask and someone is wearing a mask. Don't, you know, point and laugh at them or something. Make that more of a normal thing, especially during cold and flu season. Provide reminders to bring masks, carry masks, wear masks. I've noticed at the grocery store by the carts now, there's a sign that says, did you remember your reusable grocery bags? And sometimes I'm like, oh, right, I forgot them in the car. The same thing will work for masks. Did you bring your mask? Did you leave it in your car? Maybe you can, I have one that I actually leave in my car now. So kind of in case I forget my one that's in my purse, then I have one in my car. So just these reminders that are really helpful. Straight up provide masks. I think that's probably if somebody's in a store or a kind of a public situation like that, and the store wants to enforce a mask policy, the store should be perhaps thinking about providing masks, offering masks for sale. If any of you guys have been, I have small children, so if any of you guys have been to a McDonald's play place, not recently, but pre-pandemic, you know, socks are required, but what if you forget your socks? They have socks for sale and they're $1, right? So the same kind of philosophy applies. If you want people to comply, you have to make it easy for them to comply. And then use relevant, what I'm going to call relevant cultural symbols, make them fun and attractive. So the research study from 2018 that I mentioned, people significantly didn't like the way that masks looked. They thought they were ugly and they didn't want their appearance to be judged. That was one of the findings in that research study, which I thought was kind of funny. But I think, you know, and I'll show you some examples just now, but if you can make them fun, it kind of takes the level of anxiety down a notch. And then if you do have to confront somebody who's not wearing a mask, I would say take this perspective of humility as opposed to confrontation. So come at it with the kind of generous perspective that perhaps they just forgot or are not able for some reason to have a mask at that moment, and perhaps, you know, making it easy for them rather than coming into it looking for a fight. And I think that's, you know, this open-hearted kind of perspective is a way. Non-judgmental is another way to think of it. Is something that kind of goes through public health in general. Is let's not start fights. Let's try to be accommodating as much as possible. And that usually, you know, maybe it's the attract flies with honey approach. Okay, so I'm going to show you some examples here. Let me see, just to make sure I'm getting people's questions as they go. Yeah. Yep. So one of the questions here is whether, when you wear it in stores, required in stores versus on the sidewalk and out in the street. And I think that's a place where the evidence, that the so-called science evidence is difficult, because for a while they were saying 6 feet should be enough. Now they're saying, well, those aerosols, if somebody is symptomatic and coughing, that they could be coughing those aerosols as far away as 20 feet, which makes you kind of reevaluate whether or not to wear them outside. I tend to, when I go to the grocery store, put it on when I get out of my car and then go in. But sometimes by the time I'm done shopping, I take it off in the parking lot. So but then I'm like, well, the parking lot's not that densely populated a place. I think the problem is this is all situational. How many other people are around you? How dense are you? Where's the space to move? I would say any kind of packing whatsoever, you'd want to put it back on. But again, I'm not a MD doctor. I'm a PhD. So the kinds of things that I'm thinking about, or I think about this from a different perspective. But I wanted to share with you a little bit at some of the developments on masks, and I'm sure you guys have seen your own examples. So here's an article about masks turning into a fashion statement. So can you match your mask to your clothes, for example? This is a great design for a poster for a Native American community. I teach a class in culture and health, and we talk a lot about how to appeal to certain constituencies and making sure that you're using appropriate people in your images, the right kinds of symbols and colors and contexts. So you can see this would be kind of a culturally directed poster. It says, be the example, mask up. Here's me in my mask, and one of my masks, and I use this one because my mom made this for me. And I'm from San Diego, California originally. And so on this mask, you can see Balboa Park right up there under my glasses is a famous building. It's a museum in Balboa Park and a bridge, which is a kind of a notable San Diego place, and the USS Midway beneath it. So when I want my California pride, I put that on and go out. She's also made me one at the Arch, so I can have one for my Missouri. That's the closest she has of fabric that represents Missouri for me. And then these ones were kind of funny. These are, you can take a picture of your own face and have your face put on a mask that you wear over your face. And so this maybe helps people deal with the kind of strange social experience of not having people recognize you in public, or just feeling like you don't look like yourself, as maybe you put your face on your mask and then you wear your face out. I thought that was kind of a funny example. Other examples of having to do with the social distancing or spatial distancing, again, speaking to what people know using symbols that are important to them. So this is from a series that went around Yukon in Canada. So they had a whole bunch of these, but this is saying 6 feet is 2 huskies. So stay 2 huskies apart. And then down and below, it gives you kind of funny advice. Funny, but also correct public health advice. Resist the urge to pet any dogs. Affirmations of their very good status can occur from safe distance. And then there's a few other examples. This was, I think, from the National Park Service. Stay, 6 feet. 6 feet is apparently the distance from one side to the other side of the antlers of a caribou. Here's some others with some other examples: a yoga mat, 1 grizzly bear, the national park sign, a moose's antlers. Here's one from Florida. So you keep 1 alligator apart. So using these symbols, using these references that make sense to people in different communities. And then here's one from Japan that talks about 1 tatami mat. So again, if we saw this in America, we might not know, what is a tatami mat? How big is it? That's not a reference that's meaningful to me, but there, this is a meaningful reference. And then they have some other data below kind of explaining why that's useful. So I thought that those are kind of funny, and these are things that are, always tailoring things to community. And you can see even my slides, I'm from the University of Missouri. I've used a University of Missouri template. When I give talks to people from the university community, that's meaningful to them. So using the symbols, the signs, the colors, the contexts that are meaningful, that gets the message into somebody's mind and helps them accept it because they feel like you're part of their community. Okay, so I wanted to just give you a brief comparison. So I'm doing some research on the 1918 influenza pandemic in Missouri, actually. So the research that was mentioned at the beginning was in Newfoundland, but I've been collecting death data from the state. Our state is an open record state. So you can actually look at the death records from the state for any year from 1910 through 50, they're closed for 50 years. So whatever, this year minus 50 years. So there's a good number of decades where you can actually look at each and every death record from anywhere in the state And so I've been collecting all the data for people who died of the flu or pneumonia. And there's reasons for that I won't necessarily explain right now, but I've been going through all the different counties and looking at all the death records and collecting all this information to kind of understand the scope and spread of the 1918 pandemic in this state. And so these are just the little arrows are just what I have been collecting. You can see the cause of death here is listed as Spanish influenza. These are open records that I just like to preserve people's privacy. So I blacked out some of the identifying features. I've collected data from all the counties that are colored in here. So I'm almost done. I'm collecting the whole state. I have to do that by the end of the year for this project I'm working on. And so I can show you data from its 91 counties now. We have data from 1918 through 1920. So if you want to see what the pandemic, the 1918 flu pandemic looked like in this state, this is the curve, so the so-called curve. The 1918 flu was known for having 3 waves. In Missouri, this is the first wave around here. It's kind of at the tail end of a normal flu season. So you can see this is bumped out to May of 1918. So they had kind of an extra long flu season. The second wave is actually what I have noted here, where they had across those 91 counties in the state, we had almost 800 deaths in 1 week. And then another kind of bimodal situation here. The third wave, which is known well in the literature around the world, is not really that evident here. This would be the timing of the third wave in most other places in the world. And what was an interesting finding for me in regards to this pandemic, but also worrying in terms of COVID, is what's going on over here. You'll notice this date is 1920. Most places around the world that had the 1918 flu pandemic, it was over by 1919. And then they kind of went back to a normal flu season shortly after that. Missouri and some other places, mostly rural places around the world or kind of removed places, experienced really large flu season in 1920. And you can see that the peak of deaths, these are just counts of deaths, was almost as high in 1920 as it was in 1918, right? The wave was not as broad, so it was over in a shorter period of time, but it was an extreme number of deaths in 1920. And so I thought, oh man, I sure hope that we don't have something similar in this pandemic. And so I'm watching carefully, but this is informing how I think about this pandemic in some significant ways. And so I'll share with you what I'm talking about here. The first is that non-pharmaceutical, what's so-called NPIs, non-pharmaceutical interventions fail when they don't take into account culture. And by that I mean, just telling somebody, wear a mask, stay inside for 6 weeks, without people thinking about and trying to account for some of the countering pressures on behavior, you're going to have larger failures. And this is true across all kinds of health behaviors, right? You think about, we know it's healthier to not eat as much red meat as most Americans do, but we still eat a lot of red meat. So just hearing that word, don't eat red meat is not going to be helpful. So taking into account culture is important. We need, as health professionals and future health professionals and leaders in our communities, we need to prepare people for uncertainty. We need them to understand that the epidemic, we don't know when it will be over exactly. That's not something that's known right now. We don't know exactly how many people will die or get sick even, because there are some significant differences. The 1918 flu is a nice example, but it's not, I think somebody's mic is on. Oh, I should keep going or not. But yes, so we don't, so the 1918 pandemic is a nice model, but we can't think of it as a one-for-one model. So in the discussion in the media and various other places I've seen talking about a fall wave, a lot of that is based on the curve that I showed you before, which had that huge fall wave. We don't know if that's going to happen exactly the same way with COVID. So being careful about how we use our example pandemics. And then we need to be careful about how we communicate what experts do and don't know for sure, and how that information is contextualized for the public. and anyone else we're coming into contact with. So that's really a difficult thing to do. That's science communication. I think in general, members of the community, we need to be flexible. We need to be prepared for many openings and closings and reopenings. I have a student working with me creating a timeline of school closures in the fall of 1918. And you may be surprised to know, but schools in Kansas City and Boone County and other places in the state closed in October, reopened in November, closed again in December. So we're moving into 1919 to see what's going on in 1919. But there were many openings and closings and reopenings and reclosings at that pandemic. And I think we need to be prepared for something similar in this one as well. So with that, I think I went a little bit longer than I wanted to. Oh, right, the importance of scale. Sorry, I had one more thing because I've mentioned this already. If you are a leader in your community, if you're a small business owner, if you're a parent, if you're anybody making policy, always be aware of the scale at which the information you're consuming is collected, right? So if I'm thinking about what I'm going to do in my town of Columbia, if I'm going to go out without a mask on or what have you, put my kids back in school, I need to understand what the pandemic is doing in my town, right? I can pay attention to what it's doing nationally, and that's helpful for certain kinds of decisions. But other decisions, you need local information. Other decisions, you need state level information. And so if you're a leader or somebody who has some decision-making power, you need to always be remembering the scale of the information that you're consuming and what that means for your decision-making as well. What scale are you making decisions on as well? The decisions you make for your family are going to be different than for your workplace or the university, for example. So those are kind of my thoughts from, I was telling people yesterday, I feel like I've been living in kind of a flat time because I'm reading all this information from 1918. I'm reading all this information from now, and so much of it echoes and parallels and bounces off and interacts with each other. So it's a very interesting time to be doing this 1918 research, I will say that. So I found this nice little chalk drawing. Social distancing doesn't mean we aren't together. And so with that, I'd like to kind of end my formal presentation and have conversation and questions and hear people's examples. And I'd like to kind of recognize all the work and funding of the people who brought you the series and the people who are funding my research as well. So thank you.